Hi, everyone. Let's talk about infectious diseases. We're going to start out with herpes simplex. Here's the objectives. They don't have the herpes simplex in here because I actually added that. It's in the beginning of the chapter 8, and I didn't know why it wasn't in there, and I thought it should be, so I just added that to this PowerPoint, and I didn't change the objectives, but there's a few slides here. So herpes simplex, the treatment for herpes simplex, the antiviral medications that are out there are palliative only, meaning they sort of address symptoms. They may shorten the course of the expression of the virus, but they are strictly to make people feel more comfortable and lessen sort of that time that you have the cold sore, the visible sores, and the things that go along with it. So palliative only, not curative. It's not curing a virus. Two types of the virus, and it can occur in healthy people or in immunocompromised individuals. It may express itself more in immunocompromised individuals, but it can just as likely express itself in healthy individuals. There's herpes virus, HSV1. That is predominantly sort of thought of as above the belt, basically like oropharyngeal, on the vermilion border of the mouth or somewhere in the mouth. There's also herpes Whitthrow. We don't have to know about it, but it's the one that can occur on the hands. And then herpes can also occur rarely in the eyes, or an ocular virus, but predominantly we think of it as like cold sores in the mouth or around the mouth. Herpes virus type 2, HSV2, is primarily the sexually transmitted disease, and it expresses itself in the genital area. You can get infected with HSV1 in the genital region and vice versa, but this is like primarily where those viruses will be. It is it has neurovirulence, which means that it has the capacity to invade and replicate in the nervous system. It's dormant in the neurons, specifically trigeminal ganglia, until it's expressed. And it's not on the slide here, but it can happen from stress, sun, food. I mean, there's so many things that can cause somebody to express the virus once it's kind of in their system. About 1/3 of individuals will have the virus for a lifetime and sort of express it on like once every 6 months or once a year or more frequently. And then other people may potentially just, it might just be dormant. They might clear the virus. Other things can happen if they're just for whatever reason not as susceptible to it. The primary infection, somebody that gets the virus from somebody and has their first outbreak, very times what we'll see, if it's in and around, if we're talking about the oropharyngeal HSV1 specifically, they'll present with acute gingival. Plug in my. Plug in my microphone. Hopefully better. Sorry, I just realized that my microphone was not plugged in. So acute gingivostomatitis, that will come on strong. People will have fever. They might have malaise, nausea, vomiting. They'll have those little vascular lesions and really acute, angry gingivitis throughout their mouth. And then that lasts for a period, and then it might, sort of calm down after 10 to 14 days or so. Viral shedding, though, can continue in saliva for 3 weeks or longer after the visible sores are gone. So somebody who gets recurrent cold sores, they can still shed the virus for up to 3 weeks after that cold sore disappears. And that's really important when you're thinking about whether or not you're going to treat a patient. Subsequent outbreaks vary with individuals, and those outbreaks are not nearly as severe as that primary infection. These are some medications, antivirals for the herpes simplex. We have episodic oral treatment. There's acyclovir, famciclovir, and valacyclovir. And then you can find the brand names in the textbook. So look in the text in a lot of these. I just liked this table. It was really nicely it was clear. So I used it, but also look in the text to see the brand names and some of the applications. Episodic topical treatment, we have acyclovir cream, there's docosanol cream, and you can get docosanol, I believe, over the counter, and then penecyclovir cream, treatment to prevent recurrence. So people might, if they tend to get recurrent outbreaks, they may go on a regular prophylactic treatment of acyclovir, valacyclovir, or also they may recommend something like sunscreen to protect if they feel like sun exposure triggers an outbreak. So some things to know about for our oral considerations: elective dental and dental hygiene treatments should be deferred for patients who present with active herpetic lesions. So unless it's like a big emergency, if they just show up for a cleaning, that needs to be deferred. And you guys will find that out in our clinic as well. That's our policy. Treatment may be uncomfortable for the patient, for one, but more than that, they are at risk for spreading the infection or getting a reinfection. As healthcare professionals, we're at risk of that infection through aerosolization of the virus during the dental procedure. So it's really important that we do not treat somebody with an active herpetic lesion. Okay, so that is what pretty much the most important information to know for herpes. So now we'll move on to HIV. The first case of HIV was reported in the US in 1981, and it is an end stage of infection with human immunodeficiency virus, HIV-1 and HIV-2, and then acquired immune deficiency syndrome is AIDS. So first, HIV-1 typically. HIV-2 is something that there are some cases in Africa, but it's really very rare in the US. And then it can transfer from HIV to AIDS given certain circumstances, although nowadays it's very well controlled with medication. The virus attacks the body's immune system and resulting in life-threatening infections and cancers. So basically, the disease itself specifically is not necessarily killing the patient. It's sort of the result of the virus and how it pretty much wipes out a person's immune system, and then a whole slew of other things come into play that ends up actually killing the patient. Okay, so the pathophysiology. So HIV infects a type of white blood cell in the body. It's a very specific immune cell called a T helper cell. And specifically of the T helper cells, it's the CD4 cell. So it's a CD4 T lymphocyte, or they call it a T helper cell. These vital cells keep us healthy by fighting off infections and disease. So it's an important part of our immune system. HIV cannot reproduce on its own. So if HIV is just outside of the body, it's just going to sit there and die. It needs a host to take its RNA retrovirus and turn it into more viruses inside of a person. So HIV cannot reproduce on its own, like I said. Instead, the virus attaches itself to one of these T lymphocyte cells, the CD4 cells. It fuses with the CD4 cell, and then it takes control of the cell's DNA, making copies of itself inside the cell. And then finally, it releases more HIV or more virus into the body or into the blood. HIV continues to multiply and spread through the body. And this is basically the process of the HIV life cycle. So we have primary immune cells that are involved are the CD4. The HIV is transmissible. It's an RNA retrovirus. So this is the type of virus that it is. It's an RNA retrovirus. It's looking for these CD4 cells to infect and fuse to. Then once it does that, it allows the viral RNA from the HIV to be released into, so it kind of dumps all of its genetic material into this CD4 cell. Once it's inside the cell, it uses these particular enzymes. So it uses this cell to reverse transcriptase enzyme. That's the particular enzyme. It uses it to alter the host's DNA. So the proviral DNA enters the nucleus of the host cell, inserts into the cell's DNA, and the cell then makes copies. So that's sort of the steps of the pathophysiology. Here we have a picture of the virus, kind of shows you don't really have to know, this is just sort of a picture of it. It's showing the different enzymes, the RNA, sort of the capsid or the different components of the lipid bilayer, its outer layer, its reverse transcriptase proteins, and just all these little things. And then this is these GP41 and GP120 are probably areas where it attaches to CD4 cells, if I am remembering this correctly. We'll look here. Yes, it is. There's it's where they hook up to CD4 receptors. So I think perhaps, no, I think I'm getting confused with special needs. I use this slide in special needs as a reminder because I just really like this slide, but it basically shows the life cycle. It shows the virus, and it shows how it binds, HIV binds, or it attaches itself to receptors on the surface of the CD4 cell. And then it shows, the other thing that I really like about this slide is that these stops, stop sign, here, 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 these are all areas that different medications, different antiviral medications help patients who have been exposed to HIV. They stop different areas of the process of the life cycle of the HIV. So CCR5 and antagonist. So it's gonna interfere with its ability to attach to a receptor. Post-attachment inhibitor. Here's another stop, full stop. It's gonna affect the ability of the HIV virus from even attaching to a receptor on a CD4 cell. But let's say it does attach. So now the next thing is it fuses. The HIV envelope and the CD4 cell membrane fuse together. So you can see it's kind of fused into the cell membrane, which allows HIV to enter the cell. So now it's allowed to get in to the cell. Now, if there's a medication that's called a fusion inhibitor, and it is basically preventing the virus from fusing with the cell membrane of the CD4 cell. So this is another place where a medication might stop this process. But if it was allowed to continue, it comes in here. We have step 3, reverse transcriptase inside the CD4 cell. HIV releases and uses reverse transcriptase, which is an HIV enzyme, to convert its genetic material, HIV RNA, into HIV DNA. The conversion of HIV RNA to HIV DNA allows HIV to then enter the nucleus. It has to do this reverse transcriptase in order to get into the nucleus. So see all these steps it has to do? It's just crazy. Here we have a couple more stops. So there are non-nucleoside reverse transcriptase inhibitors, NNRTIs, that patients can take. This is one kind of medication. Nucleoside reverse transcriptase inhibitors, NTRIs. So those are 2 different medications that prevent this reverse transcriptase. So it doesn't have what it takes to go from RNA to DNA, and therefore it can't get into the nucleus. So it sort of stops the process there. That's a different medication. But let's say it does go from RNA to DNA. Now it's inside the nucleus. So now we have step 4, integration. Inside the CD4 cell nucleus, HIV releases integrase, an HIV enzyme. HIV uses integrase to insert its viral DNA into the DNA of the CD4 cell. So now it's becoming a part of the human's CD4 cell DNA. There is another stop, another kind of medication which inhibits this. It's called integrase inhibitors. But if that doesn't happen, then it would move on to step 5, replication. So now it's in the DNA, it's part of the DNA. So once integrated into the DNA of the CD4 cell, HIV begins to use the machinery. So now it's using that CD4 cell for its own advantage to replicate itself. So it's using machinery of the CD4 cell to make long chains of HIV proteins. The protein chains are the building blocks for more HIV. So you can't have more HIV virus unless you have these building blocks. So then number 6, and notice there's no stop there, at least not here. And I don't know if they've made a new medication, but this was a pretty recent figure. So anyway, so from there it'll go to 6, which is the assembly. New HIV proteins and HIV RNA move to the surface of the cell. Now it's moving back out of the cell and assembled in the into immature HIV. Non-infection, they're immature, so they're not infectious yet. So then we have to go to the budding. They have to mature. Budding, newly formed, immature, non-infectious HIV pushes itself out of the CD4 cell. The new HIV releases protease. That's an HIV enzyme. So this word protease inhibitor might sound familiar too, because they created one of the COVID-19 drugs as a protease inhibitor. But anyway, so the new HIV releases protease and HIV enzyme. Protease acts to break up the long chains, these long chains that form the immature virus. The smaller HIV proteins combine to form mature HIV, which are then infectious. And then these just keep kicking out more and more HIV, and the person gets sicker and sicker. So if they were to stop it at this late stage, they can stop it with a protease inhibitor. So that is the very broken down, but I just like that because it just shows all these different parts and then the different medications and how they come into play. Here's another figure that shows kind of something similar, but it shows the HIV virus, these steps, number 2, number 3, number 4, but I just don't think it's as clear. I don't like it as well, but I put it in there anyways. So an individual CD4 T cell count will decrease as the disease progresses because they're hijacking those CD4 cells. So decreased CD4 cell count occurs as the disease progresses, and the risk of opportunistic infection is going to increase. So the person is going to get sicker, their immune system is going to get weaker, and then these opportunistic infections, which include all of these: tuberculosis, fungal infections, so that oral candidiasis, pneumonia, recurrent bacterial pneumonia, diarrhea, meningitis, and cancer such as Kaposi's sarcoma and non-Hodgkin's lymphoma. So all of these are just opportunistic infections waiting for somebody's resistance to diminish so that they can come in and wreak havoc. So as the amount of virus in the plasma, in the blood, the viral load in the blood increases, the CD4 count will decrease. And so basically somebody is considered to have converted from HIV to AIDS if their CD4 count is below 200. That's what is the basic, you always hear, do they have AIDS or do they have HIV? Well, it's based on their CD4 count, and it has to be less than 200. So there's treatments here. There's the acronym is HAART, H-A-A-R-T, highly active antiretroviral therapy. Highly active antiretroviral therapy consists of at least 3 to 4 drugs typically, and certain classes are used more than others. So there's remember the NRTI from that figure. So 2 types of nucleoside reverse transcriptase inhibitors, a protease inhibitor, Those are the most common. And then it's just sort of a cocktail, I guess, of what works for people. Here's another similar figure. So one thing, I don't expect you to necessarily memorize every single drug. These are, there's a lot of drugs here. But what you should notice is that VIR is in almost all of them. So you may become a little bit more familiar with the herpes simplex, and then be able to recognize those as opposed to memorizing all of these HIV and AIDS medications. But do notice that tenofovir, efavirenz, atazanavir, and notice these are like combination drugs, and fuviratide. I'm probably pronouncing all of them completely wrong, but Maraviroc. So all of these have VIR. And so if that should be something to kind of help trigger you that these are antiviral drugs, and there's going to be, you are obviously going to know most likely that your patient is HIV positive, and they'll have their list of drugs. So what are the oral infections that we are concerned about with patients that are HIV positive or have AIDS? Like we said earlier, we're concerned with fungal infections, oral candidiasis or angular cheilitis, viral infections such as herpes simplex, if their immune system is lower, and then also papillomavirus and hairy leukoplakia are also viral infections that we'd be concerned with them popping up because of their compromised immune system. Bacterial infections, periodontal disease, of course, they're going to be more at risk for this. Aphthous ulcers or canker sores, they might just have mucositis or sores in their mouth. Small blood-filled petechiae due to anemia, so they may be anemic, and so we could see those little petechiae in the oral cavity. Xerostomia is a common complaint that can also be with patients with candidiasis. And then oral neoplasms such as the Kaposi's sarcoma, and those can be intra or extraoral. And we'll talk more about those in a minute. So here's some pictures of oral candidiasis. Here's a picture of an extraoral Kaposi's sarcoma and an intraoral. It's a neoplasm that's looks almost like a bruise, really, but you can see it's overgrowth of these blood vessels, and it just usually always looks kind of dark purpley, blackish blue. My notes here, let's see, what does my notes say? Kaposi's sarcoma is considered an AIDS defining illness. So this was one of the first signs when the AIDS epidemic first came around. Many of the patients had this. This means that when Kaposi's sarcoma occurs in someone infected with HIV, that person officially has AIDS, and it's not just HIV positive. So this is sort of one of the signals that they've converted basically from HIV to AIDS. Kaposi's sarcoma is a cancer that develops from the cells that line the lymph or the blood vessels. That's kind of this dark reddish purpley color. It usually appears as tumors on the skin or on mucosal surfaces, such as inside the mouth, but these tumors can also develop in other parts of the body, and it's purple, red, brown blotches or tumors on the skin. Here are some other examples of it. That just looks pretty nasty. Hairy leukoplakia, white patches, side of the tongue, and corrugated are some of the oral manifestations of hairy leukoplakia. And then, so that's all that we're going to talk about for HIV. That's all that we have in the PowerPoint. So now we're going to move on to bacterial infections. Okay, so we're going to pretty much just be talking about tuberculosis here. So here's a little video you can watch. This is basically a clip from the movie. Oh goodness, what is that? Oh shoot, it's with Val Kilmer. It's an older movie, and he plays Doc Holliday, who in real life
died of tuberculosis. So the video clip, just to be a spoiler, it shows the actor kind of sweating and just looking kind of gray and pretty awful. And so so it says here to take notes of the signs and symptoms, because as you look further on in the PowerPoint, you'll see some of the signs and symptoms. They kind of had him acting them out in the movie. So Doc Holliday, an American gambler, gunfighter, and a dentist. I remember finding that out last year when I first looked into him a little bit more, and I thought that was funny. I didn't realize he was a dentist, but he died from tuberculosis, and he contracted it from his mother while he was taking care of her, which is kind of sad. She died of tuberculosis as well. So the etiology tuberculosis, it's a bacterial infection. That's important for you to remember for quizzes and exams. Mycobacterium tuberculosis is the specific bacteria. The name indicates its formation of firm nodules or tubercles throughout the body. So we think of it as a lung disease, but these tubercles can be other places in the body. Microorganism is inhaled through the aerosol droplets, and the number of organisms inhaled and immune system determine whether the disease is contracted. So it's really not super easy to get tuberculosis. You have to be pretty intimately involved with somebody for a while. So it takes a prolonged exposure in order to become infected. So typically it would be from a family member or a close coworker. Not everyone who's infected with tuberculosis, the bacteria, will develop clinically active tuberculosis. And then individuals with weakened immune systems are, of course, at greater risk. Therefore, that's the connection with HIV and AIDS. So the pathophysiology, it can infect any organ of the body, but most commonly we think about it with the lungs, with chronic coughing and what have you. Droplets are carried into the alveoli. The host defenses control and contain the infection, resulting in a latent tuberculosis. So if it's sort of contained and controlled, there may not be a lot of outward expression, and it can happen. It can happen later, like however long after the initial exposure. That's why they call it latent, because it doesn't show up like right away. So if it's not contained, granulomas form, eventually causing necrosis. And then, like I said, as a rule, it's pretty difficult to get it. You have to spend a lot of time frequently in close proximity with someone in order to get the disease. So a person may contract pulmonary tuberculosis from inhaling infected droplets, and then the granuloma will form in the lung tissue. Here you can see there's a picture of it, and then this is just a autopsy of a lung of somebody who died of tuberculosis. Looks pretty terrible. So signs and symptoms, 4 to 6 weeks after initial contact, there might be fever, chills, GI upset, and night sweat. So some of that acting from that video of Doc Holliday sort of shows some of that. And then the later symptoms, once it goes from a latent to an active tuberculosis, there's weight loss, nausea, vomiting, headaches, palpitations, a very productive cough that can be yellow, greenish, or have blood in it. So treatment, pharmacological management for tuberculosis, patient compliance to prevent resistant strains of the bacteria. So it's a very long course of treatment, and patients need to take it even though they very often start feeling better and don't think they need it. And so they don't want to finish their course of treatment, but it's important. There's vaccine with unpredictable efficacy, so vaccine's not really an option. And of course, no elective dental treatment if somebody has active TB, and you find that sometimes we'll get people in our clinic who had TB, and so we need to have a cleared note from their doctor, either a cleared chest x-ray or proof that they went through the whole course and they have a cleared from their doctor. So duration of the therapy is based on the drug regimen, must be long enough to eradicate the disease. So there's a selected first line of drugs. You can see here, let's see, isoniazid, INH. This is for both active or inactive. So if somebody doesn't have specific expressing of the disease, they could still be taking this. Rifampin is for active tuberculosis. This one is going to be, you'll see this one probably more often. And then pyrazinamide and ethambutol, those are also for active tuberculosis. But the first two, isoniazid and rifampin, those two are selected for as anti-tuberculosis drugs, highly specific for the specific bacteria, Mycobacterium, and activities for rifampin, activities against Mycobacterium tuberculosis, several other Mycobacteria species, and non-tuberculosis Mycobacteria. So these are really very popular drugs to be used. So these two you'd probably see the most. So that is it. And I wish I had it here, but the course is like 6 to 9 months, and that should really be on a slide. I don't know why. Oh, I have it in my notes here. Latent or inactive tuberculosis, the most common preventative therapy is daily dose of the antibacterial isoniazid taken as a single daily pill for 6 to 9 months, and that's preventive. And then if you have active tuberculosis, the most common treatment is isoniazid in combination with these drugs here. So active, so if you're inactive, you might just be taking isoniazid. If you're inactive, you may be taking multiple. And drug therapy can last 6 to 12 months. I don't know about how often it goes a year. I thought I remembered 6 to 9, but I know the course of treatment is very long. So, okay, so now we'll move on to autoimmune disorders. All right, so autoimmune disorders, this is kind of a funny, it's a little bit funny the way this section is in here. I don't feel like it's entirely, what's the word I'm looking for? Inclusive of all the possibilities, but anyways, this is what's in here. So this is what we're going to review. So rheumatoid arthritis, it's characterized by inflammation in the joints. So symmetric inflammation in the joints, and it's actually the synovium to be specific, but the etiology is unknown. Genetics and environmental factors may play a role. And what happens is there's swelling in the synovium, and then granulation tissue forms because of this, because of what it happens initially, this swelling. So a lot of times in the inflammatory processes, you get a lot of granulation tissue formation, which is sort of like new vessels, new blood vessels, new things like that. And it's can cause some of the problems, but it's sort of a response to an inflammatory process. So lymphocytes and plasma cells, they infiltrate into the area. So that's some of these granulation tissue. Granulation tissue eventually covers the surface and it starts to destroy the cartilage. So this sort of inflammatory response starts to be the problem. New bone and fibrous tissue deposit, resulting in fusion and then loss of mobility. So the disease process is essentially inflammation, process of the body attacking the synovium or the lining of the joints, and the inflamed synovium gets thicker, makes the joint area feel painful, tender, hard, sort of hard to move. That's why they say, like, you know, people they feel real stiff in the morning, but once they get going, they feel a little better. So here we have a picture, here's the cartilage, and then here's a picture of sort of this encasing, the synovial membrane. Osteoarthritis is a deterioration of the cartilage and overgrowth of bone, often due to wear and tear. Rheumatoid arthritis is the inflammation of the synovial tissue, leading to destruction of the cartilage. So two different osteoarthritis versus rheumatoid arthritis. Rheumatoid arthritis symptoms, joints and muscle aches, swelling, the TMJ can be involved. So as people age and their TMJ, their temporomandibular joint gives them problems, and they can have TMD or temporomandibular disorder. And then you can see how really severely it can really, from that buildup of tissue and bone, it can totally distort and deform different joints. pretty severe there. Treatment, disease modifying anti-rheumatic drugs. So this is a term to memorize, DMARD, DMARDs, basically you could say DMARDs, disease modifying anti-rheumatic drugs. That's what it stands for. And that includes methotrexate. So that's an immunosuppressant, methotrexate. So that's one to remember. Leflunomide, and then hydroxychloroquine, that might sound familiar because that was talked about during COVID as well as a potential treatment for COVID-19, hydrochloroquine. So that's oftentimes given to patients who have rheumatoid arthritis, and then sulfasalazine, and corticosteroids, so immunosuppressants or anti-inflammatory medications. They may be used to treat many disease states, including rheumatoid arthritis. Use in a variety of diseases, including allergic, inflammatory, and various autoimmune diseases. Mechanisms for inflammation, suppression of migration of leukocytes, regulate cell metabolism. So these DMARDs can be used for various autoimmune diseases. There's like, I don't know, over 100 autoimmune diseases. There's many different ones. These drugs not only relieve symptoms, but also slow the progression of joint damage. Often doctors prescribe DMARDs along with nonsteroidal anti-inflammatory or NSAIDs or a low-dose corticosteroid to lower swelling and pain. So Cushing's syndrome this can happen for a number of reasons. It can be caused from an overuse of cortisol medications. So people could develop this due to medications that they're on, excess production of cortisol from a tumor. So that's another reason that this condition, Cushing syndrome, may happen, is due to a tumor in the adrenal gland or somewhere else in the body that's pumping out excessive cortisol, like mega cortisol. A tumor of the pituitary gland is another, secreting adrenocorticotropic hormone, or HCTH, which stimulates the overproduction of cortisol from the adrenal gland. So overall, this cortisol is the culprit here with Cushing syndrome. But there's several things that they point out. This kind of striation, these stretch marks, abdominal stretch marks, you can see it in the arms as well. The thinner legs, easily bruising. And then they call this, there's a couple terms that I just hate because I just feel like they sound awful, but you'll see that they might even be on the national board with this verbiage. So I think it's important for you to know these verbiages. But this fat pad that can form on the back of somebody's neck, they call it a buffalo hump. And then the face, if it's very swollen, sort of this, they can call it a moon face, can be the way it presents. And so those terms, moon face and buffalo hump, they could potentially be on the national board. And so that's ways of describing. So these are various, and you can kind of see how it looks on somebody in real life. So this person is suffering from Cushing syndrome, and this is a direct result of something to do with the amount of cortisol, whether it be excessive medication or if it's something like a tumor or something like that. So it can be different reasons. Okay, so treatment of Cushing syndrome depends on the underlying. So if they have a tumor or something, obviously they're going to have some kind of like treatment or radiation, chemotherapy. They're going to do something to inhibit that cortisol production. In patients to whom they're in remission, is not obtained after surgery, there's various medications that inhibit the production of cortisol. And these are some of these medications. You don't have to memorize these. These are just sort of extra, but you don't have to memorize these medications here. But I do think it's important for you to know for sure methotrexate and hydroxychloroquine. I don't know that these medications pop up on any exam, but for sure methotrexate does. At somewhere along the line, you should know that's immunosuppressant. All right, so some miscellaneous stuff here. We're going to talk about the blood a little bit, talk about components of the blood. So what's in your blood? So it's important to know sort of these overall percentages here. 58% of your blood is plasma. And well, what's in plasma? Plasma is water, ions, vitamins, various waste products. Platelets, these are what have to do with your clotting. They are suspended in the plasma, and they're also called thrombocytes. Platelets produce tiny fibrin threads, and they sort of form like a web-like mesh that traps blood cells, and that's what forms a clot. Then you have your red blood cells, which make up roughly 42%. So plasma and red blood cells are most of what your blood is. But then you have white blood cells, and this is your immune defense and phagocytosis. They eat up the stuff that, you know, your body sort of is getting through, like part of your immune system might have some kind of bacteria or something that enters your body. Phagocytes will get rid of them by basically eating them. And then backtracking a little bit to red blood cells, they carry oxygen and CO2. They contain hemoglobin, oxygen carrying molecules, and there's no nucleus. They're the little things that kind of look like a donut without the hole punched out. So inside your white blood cells, they are produced in the bone marrow, and this is where we get our T cells and our B cells from, but they're produced in the bone marrow, and they're made up of granulocytes, which are mostly neutrophils, so about 90% are neutrophils. Then you have the rest of them are eosinophils and basophils, and they are inflammatory and allergic reactions. That's when they come into play. We also have our lymphocytes, which are B cells and T cells. They are specific immune responses. So it's a learned response to some kind of a foreign invader that our body has encountered before. They also produce antibodies to help us fight different things that we have been exposed to in the past. Then there's monocytes and macrophages, and they have lots of diverse functions. This is a very, very, very overview of all this. White blood cells, the range of white blood cells in a healthy person is anywhere from 4,400 to 11,000. High levels of white blood cells is basically puts you into leukocytosis greater than 11,000. The possible causes of that could be pregnancy, exercise, emotional stress, infection, if your white blood cell count is very high. If your white blood cell count is very low, less than 4,400, that could be indication of early leukemia, or possibly an effect, a toxic effect of a drug that was taken. It can lower your white blood cell count, if certain drugs can do that, or chemotherapy can do it as well. And that's called leukopenia, when your white blood cells have lowered the amount below 4,400. So true or false? The answer is in the notes. Leukemia is more common in children. So I'll let you read that answer in the notes later. Disorders of white blood cells. So we have leukemia. It's a cancer of the white blood cells, 9 times more common in adults than children, with half of the cases occurring after the age of 65. We just think of leukemia as a childhood disease because it's one of the cancers that happens in children, but overall it's more common in adults. The etiology is unknown. Host factors, chromosomal abnormalities such as Down syndrome, environmental factors, radiation or chemicals, and then viruses can trigger leukemia, but that's very rare. And then our signs and symptoms: bruising easily, fatigue, bone pain, oral ulcerations, unexplained bleeding, pallor of the gums. You see kind of this pallor means kind of a paleness. Treatment: chemotherapy kills the cancer cells by damaging the cell's DNA, targets the fast growing cells of the blood cells. Radiation and bone marrow transplantation, where they wipe out all of the person's bone marrow natural immune system, and then they inject brand new. And we'll talk a little bit about that actually at some point. I think actually we talk about it in special needs. Oral side effects of neoplastic anti-neoplasm treatment or cancer treatment. Xerostomia is a big one. Xerostomia for sure. Candidiasis, big, and mucositis. Big. Those are the three main things that are the oral side effects. So we have to prepare our patients for that through education before they go into therapy, cancer therapy, but also be prepared for possibly getting contacted by an oncologist to help them. But some things we want to help them understand: they might need some salivary supplementation, some things to help them with dry mouth. They may need to take a systemic antifungal. And then there are different things that they can do by keeping their oral environment very clean. That can help with mucositis. By keeping their oral environment moist can help with mucositis. There's rinses that can also help with pain and the sores that can come up. So there's different things that they can do to minimize the incredible discomfort of mucositis. Because you can see something like that. Think about a tiny little cold ulcer that you can get, just a tiny one, and how painful they are. These are major painful, and they can interfere with ability to eat, just overall quality of life. So another drug that's related to the bones, osteoporosis. Osteoporosis results from an unhealthy imbalance between two normal activities. So you have your resorption of bone cells, which is normal, and then you have the formation of new bone cells. So osteoclasts takes away, osteoblast builds. This is sort of a normal process that's happening. Your bones are sort of turning over. But the rate of formation is inadequate to offset the rate of resorption. So they're resorbing faster than they're forming. Therefore, we get holes in the bones. They become bigger and bigger, making them more frail and easier for patients to break a bone. So for prevention of osteoporosis, a large body of data indicates that optimal calcium intake reduces bone loss and suppresses bone turnover. Routine to recommend supplement of vitamin D. That's a really important aspect as well, vitamin D. Exercise in young individuals increases the likelihood of attaining the maximal genetically determined peak bone mass. So sort of the pounding of our bones through like running or weightlifting or walking, like especially when we're young, sort of sets us up for nice, good, dense bones when we're older. Meta-analysis of studies performed in postmenopausal women indicate that weight-bearing exercises prevent bone loss, but does not appear to result in substantial bone gain. So it sort of just sets you up for your best chances, if you do this stuff when you're young. Bisphosphonates are a medication. It's a #1 line of therapy for prevention and treatment of osteoporosis. Intravenous is used most often in cancer patients with hypercalcemia. They have a lot of calcium in their blood. So this can be used, bisphosphonates can be used with cancer patients for a different reason than osteoporosis. It has more to do with hypercalcemia in the blood. However, let's see, we might not be getting into it. So the mechanism of action for bisphosphonates is it mimics pyrophosphates, which is an endogenous resorption inhibitor. So it's preventing those osteoclasts. It's preventing the resorption of the bone. All bisphosphonates become incorporated into the bone matrix. So they all become a part of the bone, and they have a half-life, remember half-lives, of up to 10 years. So when you take a bisphosphonate, it is hanging around for a decade. So that leads us to some things that we really need to know about bisphosphonates. Fosamax will be, and Boniva. These are probably the two. Actonel, those are maybe also, but Bonivia, notice it's an IV. Fosamax is by mouth. A lot of osteoporosis patients take Fosamax, but just kind of be familiar with this, but have Fosamax resonate as a by mouth oral bisphosphonate. And then IV are typically patients will take IV doses, like I said, if they have cancer, but also they could take it if they're have osteoporosis, although I don't think it's as common. This is another chart that goes over the different bisphosphonates. Let's see. Okay, so adverse effects, mostly GI, abdominal pain, nausea, but the big one, this should be like flashing red, is osteonecrosis of the jaw. Osteonecrosis of the jaw, here's some exposed bone. This is exposed bone here. And what's happening is it doesn't heal over. So we don't get the tissue healing over and covering the bone. The bone is exposed to the outer world. That's osteonecrosis of the bone. Bisphosphonates and dental implications. Osteonecrosis of the jaw. Mechanism, it's related to suppression of those osteoclast activity. Unable to really identify who's at the greatest risk, but we know that IV patients who have gotten IV bisphosphonates are at the greatest risk, but has occurred with patients after oral surgery or who have dental or periodontal infections. So let's say somebody takes IV bisphosphonates, they take Boniva, and then they need to have a tooth extraction or some kind of an oral surgery. They are going to be at a risk of osteonecrosis of the jaw. But it can also happen spontaneously, but most often we see it with those two things falling in line. IV, it's given to them IV, and they have some kind of a dental or periodontal or oral surgery. The risk factors definitely seem to be linked to the potency of the bisphosphonates, things like these various oral surgeries, patient with a history of disease, those all seem to increase risk. Then here we can see some pictures here of the oral of the, oh my goodness, I was looking at the pictures and I totally lost my train of thought, but you can see some examples here of ONJ, osteonecrosis of the jaw. Just was trying to figure out if this was like the same person, but no, these are all different areas. I was thinking that this might be related to this. That's why I got completely sidetracked, but I guess not. Okay, so that's it. And I kind of feel like there's a little bit of information missing now that I've gone through this. I think there's some things missing. We talk about this again in special needs. I think that's probably why I feel like some information is missing, because I think I add a few things such as the main one, there's a board review question that I found in one of my board reviews, and it talked about cutting off blood supply as being a risk factor for ONJ, but really some of the main mechanism of action you can see here is that osteoclast activity is suppressed. So it can have some different reasons for why it manifests itself in patients. The biggest thing that you have to worry about for this course, however, is not so much the osteonecrosis of the jaw. We'll touch on that again more in special needs, but just having some familiarity with what some of these medications are called. Reclast, Boniva, Fosamax specifically for osteoarthritis or osteoporosis patients. Sorry, getting confused on the terms. So that's the biggest one that I would want you to be familiar with as far as a medication. Okay, that's a really long video. Hope you guys watch it. See you later.